Hello and welcome to today's teleconference. At this time, we are currently waiting for all the participants to arrive. Thank you for your patience and please continue to hold.
Hello everyone, welcome to today's webinar, Practical Implementation of the 2016 ATS CDC IDS Treatment of Drug-Susceptible Tuberculosis Guidelines, Caveats and Controversies. I'm Jennifer Kern, the Director of Education for the Mayo Clinic Center for Tuberculosis. Thank you for your participation today. We are anticipating close to 1,000 people will listen in to today's webinar. You will find connection information and helpful numbers on the lower left of your screen. Today's webinar is jointly sponsored by the Regional Training Medical Consultation Centers, the Southeastern National Tuberculosis Center, the Curry International TB Center at UCSF, the Rutgers Global Tuberculosis Institute, and the Heartland National Tuberculosis Center, and the Mayo Clinic Center for Tuberculosis. The views written and expressed in written materials and by speakers and moderators do not necessarily reflect on the official policies of the Department of Health and Human Services, nor does the mention of trade names, commercial practices, or organizations imply endorsement by the U.S. government. With our large audience today, we may have viewers who are not familiar with the 5 regional training medical consultation centers. These centers provide training in areas related to TB and medical consultations concerning tuberculosis within a particular region in the United States. However, both the products and webinars produced by these centers are available to you, our nationwide audience. Connect with your regional center through the CDC website listed on your screen. The Center for Disease Control and Prevention is an accredited provider for continuing nursing education by the American Nurses Credentialing Centers Commission on Accreditation. This activity provides 1.5 contact hours. To receive your continuing education hours, you must 1. Attend this webinar, 2. Complete the online evaluation, and 3. Complete the CDC TCEO instructions by February 24, 2017. The University of Texas Health Science Center at Tyler is accredited by the Texas Medical Association to sponsor continuing medical education for physicians. The University of Texas Health Science Center at Tyler designates this live activity for a maximum of 1.5 AMA PRA Category 1 credits. Participants should only claim credit to commiserate with their extent of their participation in this activity. To receive your continuing education hours, you must 1. Attend the webinar and complete the online evaluation. CME certificates will be emailed individually to individuals who apply for CMEs and successfully complete the course evaluation. Please allow 1 month from the date of the webinar. CNE certificates will be made available on the CDC TCEO website upon successful completion of the CDC TCEO requirements. Certificate of attendance will be provided upon request for those who successfully complete the course evaluation. Please allow 1 month from the date of the webinar. Our disclosures. In compliance with continuing education requirements, all presenters must disclose any financial or other associations with the manufacturer's commercial products, supplier of commercial services, or the commercial supporters, as well as any use of unlabeled products or products under investigational use. CDC, our planners, presenters, their spouses, and partners wish to disclose they have no financial interest or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Planners have reviewed the content to ensure there is no bias. Planning committee reviewed the content to ensure there is no bias. Presentations will not include the discussion of unlabeled use of a product or product under investigational use. Our learning objectives for this webinar. At the end of this webinar, participants will be able to discuss the practical implementation of the new treatment guidelines. We have quite the large audience today, and we have muted all of the phone lines. If you have questions, please use the Q&A box at the bottom right side of your screen. Please start your question with the vignette number and follow with your question in the example provided. It will be difficult to answer the number of questions anticipated. The panel will put forth every effort to respond. And now let's get started. Our facilitator today is Dr. Dave Ashkin. Dr. Ashkin is the Medical Director and Co-Principal Investigator for the Southeastern National Tuberculosis Center and is the Medical Director for the Florida Department of TB Health Program. Dr. Ashkin will introduce our other presenters as we go along today. So with that, Dr. Ashkin.
of all, welcome. I'm so sorry about that glitch. We're so happy to have you guys join us today. On behalf of the 5 centers, we're thrilled, and I think this is going to be a lot of fun today. As you're aware, this is a follow-up to our first webinar, which really went over the technical aspects of the official ATS, CDC, IDSA clinical practice guidelines for the treatment of drug-susceptible TB. Today we thought we'd do something a little different, which was the idea of maybe taking some clinical aspects and how they may be utilized in context of these new clinical practice guidelines by a number of our participants. And we're very, very lucky to have a great panel. Just a little background, though. As you know, it's been 13 years since our last treatment guidelines, and a lot has changed. I mean, let's look at what's happened. Over the last 13 years, TB in the United States has declined by 36%. There's been new drugs, there have been new diagnostics, and some new information. But, you know, it was that time to come back and look at what we're doing again. And one of the biggest things that's changed is the way we write the clinical practice guidelines in and of themselves. I mean, there's been a consensus now that we wanted to change. In the past, as you know, we used to use like A, B, and C recommendations and say that 1, 2, or 3, depending on how much information was there to really give the credence to those recommendations. But that's been slowly changing. In 2006, the American Thoracic Society recommended that we change the way we grade the quality of evidence and strength of recommendations, and they came up with what was called the grade system. It was also recommended that we ask what was called PICO questions, and these questions are specific questions based on patient populations, interventions, comparisons, and outcomes. So this way a specific question could be asked and then researched and looked at what evidence exists to support those recommendations, and that's what the grade system's all about. But before we start, I really want to emphasize exactly what the people who developed this system meant, because they said in the paper that clinical practice guidelines offer recommendations for the management of typical patients. These management decisions involve balancing the expected benefits and downsides, which are harms, burden, and cost. To make evidence-based medical decisions, though, clinicians also need to integrate recommendations with their own clinical judgment and with individual patient circumstances, values, and preferences. And this is what I really like. They go on to state, and I want to emphasize this over and over today, that clinicians, patients, third-party payers, institutional review committees, other stakeholders, or the courts should never view these recommendations as dictates. Even strong recommendations based on high-quality evidence will not apply to all circumstances and all patients. And consumers of these clinical practice guidelines may reasonably conclude that following some strong recommendations based on high quality will be a mistake for some patients, that these are not for everybody. And no clinical practice guidelines or recommendations can take into account all the often compelling unique features of individual clinical circumstances. Thus, nobody charged with evaluating clinicians' actions should attempt to apply recommendations in a rote or blanket fashion. And that's what today is all about. You know, one of the things that I think a lot of people are very, very uptight about is that a lot of these things may go and, you know, may go against what you've done, or maybe, you know, maybe you don't have the resources. Today what we're going to really discuss is different vignettes, but I want to emphasize what we're going to be doing today is looking at how different participants, how different clinicians, nurses, TB program managers, TB program controllers may be looking at these guidelines and how it can guide clinical practice. With that, you know, this is going to be a very clinical conference today. This conference is going to be based on questions that we got from the first and what all of us are kind of seeing. These are vignettes that are meant to stimulate discussion and really meant to look at how different people might interpret or maybe utilizing these guidelines. But at the end, I want to emphasize this over and over and over again. These are not thou shalls. These are not community standards. You set the community standards. These are really to be understood as that we always have to apply these guidelines as what's appropriate to the individual patient and obviously what programmatic resources and experiences and recommendations are. So with that, I mean, we're going to be discussing 9 vignettes. They've been formulated to stimulate the discussion among our clinicians. They're based, at least they take out some of the more interesting parts of the new clinical treatment guidelines. But over and over again, I want to emphasize how important it is that these discussions will, while they emphasize different parts of the guidelines, we have to emphasize that decisions concerning specific TB patients should be based on the individual patient's characteristics, their specifics, what resources available, and obviously, over and over again, what individual programmatic experience you have. And with that, I want to emphasize that we would beg you over and over again to look at what your experience has been with, and then adjust these clinical practice guidelines based on what you feel is best for your program and for your patient. We are very, very lucky today to have 7 outstanding participants. We have Pete Davidson. He's the TB Program Management for the Michigan Department of Health and Human Services. He's also the president of the National TB Controllers Association. We have Sue Dorman. She is an associate professor of medicine at Johns Hopkins University. We have Alfred Lardesball, who is the executive director of the Global TB Institute. We have Phil LeBeau, who is the director of the CDC Division of TB Elimination. Barbara Seaworth, the famous Barbara, who we all know is the medical director of the Heartland National TB Institute. John Wilson is freezing up in the Mayo Clinic, and he's the program director of the Mayo Clinic Center for TB. And Patty Woods is the nurse manager at the Lattimore practice at the Global TB Institute. And this is just going to be, we're going to open up these discussions, and we're begging you, please go ahead. If you wouldn't mind, if you would go ahead and you would ask questions and chat, and we'll then try at the end of this to try to answer some of your questions that may have come up during these vignettes. So without further ado, if it's okay, let's go forward and let's start vignette number 1. And we're going to ask John Wilson, we're going to ask Peter Davidson, and Patty Woods, as well as Susan Dorman, to discuss this. So guys, are you there? Say hello for me.
Hello. Hey.
All right. John, is that you up there? Are you surviving the cold or what?
We're doing okay. We have our space heaters on, so we're good to go.
All right. So let's start with this, and we always start off with a bang here. This is the one I think that's getting by far the biggest intense discussion, which is the guidelines recommend that the preferred frequency is once daily for both the intensive and continuation phase. But in some of our areas, it's not that easy to do TOT, every day, and sometimes we have to do intermittent. And in this case, a nurse in rural Nevada has to drive 3 hours round trip to provide directly observed therapy to a patient. So I guess the question is, what would you do in those kind of situations? Obviously the number 1 recommended is daily throughout, but sometimes we have to make adjustments. So what are you guys, I'm going to turn it over to you guys, what are you guys doing in situations like this, and how are you applying the new practice guidelines? John, you want to start?
Sure. Now, this was a terrific vignette that generated a lot of discussion, both within our circles here in the Upper Midwest and colleagues across the country, both with the publication of the new guidelines that nicely rolled out this past year, and focusing on, an ideal situation where providing DOT daily throughout both the induction and the continuations of phases of treatment would be the ideal situation, but the reality of many areas in the U.S. that are large rural-based areas like Nevada, where daily DOT throughout the entire program can be more challenging in that regard. And I think in this context, it's always difficult to find a specific solution, because the solution, I think, is going to be different and predicated on a number of different issues. And so, for example, when I look at a case like this, there are 3 basic points that I focus on to determine what regimen, what approach might be optimal for this particular patient. So the first one basically is the patient, his or herself. For example, the severity of disease. Is this a higher organism burden that can be found with cavitary disease, smear positive? Is this a very sick individual? Also, is this an HIV-infected individual or somebody with an immunomodulatory or immunosuppressive condition? Does this individual have other comorbidities that may impact a successful therapy, like GI malabsorptions or some mental health concerns? I'll also look at concerns for drug resistance for this individual with tuberculosis. So, for example, is this individual's first diagnosis of tuberculosis, or is this a retreatment, raising the concern for possible drug resistance, especially in an individual who did not have directly observed therapy as a part of their case management previously? Is this an individual born outside of the U.S. from a high endemic drug-resistant tuberculosis region of the world? Is this an older individual, for example, who may have underlying COPD, chronic lung disease, who may have had quite a bit of fluoroquinolone-based exposure that may lend itself to quinolone resistance in that capacity? And then thirdly, and I think very important, is looking at the local health resources with the state and county health departments, what their resources are for case management and directly observed therapy. Is there the personnel available for daily DOT, or are resources stretched and personnel not available such that a more intermittent treatment program would be more appropriate in that regard? So looking at all these together, all of these factors, I think, could lend one to more comfortably look at the regimens offered in the new guidelines and select the regimen that would be most appropriate for that situation. So, for example, in an individual with a higher organism burden of disease, an individual who may be immunosuppressed, HIV-infected, an individual that I was concerned had either confirmed or suspected drug resistance, or with health resources that perhaps might be more abundant with personnel to do more frequent DOT, I would try to do as much daily therapy as I could. But when we're getting into situations where, and using this particular vignette, in Nevada, especially the northern counties and eastern counties, where it is quite a drive to get out to many of these communities, intermittent therapy, I think, is going to need to have a serious consideration in this context. And so one might look at options of considering daily DOT up front and then perhaps intermittent thrice weekly therapy during the continuation phase, or even beyond that, whether intermittent all the way through or such, but again, based on the situation that presents itself with the patient, concerns for the severity of disease, drug resistance, and public health resources.
I mean, John, that's perfect. I mean, I think the emphasis, again, being that you have to look at the patient, you got to look at your program and what resources you have. I mean, one of the things that a lot of people are chatting about right now is, how about also extenders of DOT, such as, let's say, video DOT, or maybe having somebody else do DOT. John, Peter, Patty, or Susan, any comments on that?
Yeah, David, thank you. This is Peter. You actually read my mind. I was going to chime in and say I think this particular vignette is a great example for considering video DOT. Many programs have started to experiment with this, and some programs are really implementing it quite broadly. There are a number of, sort of considerations that go with that. It is optimal to try and make sure that if you do video DOT, you have a secure platform, just to make sure that any kind of, the sensitivity of what's going on, that it's not, available to anybody else outside of the case manager and the patient. So that was one thought. And then I think that, this kind of gets into a little bit of interpretation, but I mean, to me, as a TB controller, I think, as John said, you have to balance what, sort of what your capacity is with sort of the desire to achieve maximum benefit. And, when I was looking at this vignette, I kind of went back and forth. I kept comparing between regimen 1 and regimen 2, and I kept looking at the notes, and there's a note that basically says, regimen 2 is preferred when daily DOT is difficult to achieve. So, I mean, to me, as a controller, that's kind of where my mind goes. And I just kind of wanted to maybe add a question to the discussion at this point is, I think what a lot of from the NTCA perspective, what we're hearing, I think, is that a lot of programs are struggling to sort of balance this issue of capacity against, the beacon on the hill, so to speak. I mean, I think everybody would probably like to do daily DOT if they could, but the reality is that a lot of programs may not be able to. And so really my question is just kind of maybe broaden this vignette a bit is, is having some DOT better than having no DOT?
Right, and I think and I think you'd agree exactly, Pete. And I think the question is like, if you're going to be doing daily, does that mean that some people do it by self-administered? And what is the concern there? Susan, any comment on that or your perspective from that?
Well, just a reflection on some of the comments I've heard just a few moments ago, and really, David, your introduction and the first two speakers were spot on, and I'll just reemphasize that in formulating the guidelines, our charge was to review the available published data, and the focus really is required to be more on efficacy, and that is, how can these regimens function under ideal circumstances? And I think the challenge before all of us as TB clinicians and program people is that most of our conditions really aren't ideal. And so as a guidelines committee, we tried to present the information as it came from the evidence, but also provide language that was flexible to allow programs to make decisions that worked best for patients. And also we tried to provide some information about what some of those circumstances, at least clinical circumstances like cavitation, et cetera, might be and might enter the thinking of the clinicians.
I agree. Thank you very much, Susan. Patty, from your perspective, from a nursing perspective, I mean, how do you see that these, the utilization of daily versus intermittent may affect what you do day in, day out?
So one of the things we do look at here when we're looking at putting people on intermittent therapy and DOT is we look at the patient too. Like some patients, they might not be able to do intermittent therapy because they won't take it. So you really have to look at the patient. Some patients, they'll be fine with doing intermittent. They'll be there. They won't miss doses. But as a nurse, to have a nurse that goes out for 3 hours a day, that's really going to be difficult, especially if she does other things besides TB. So
you're right, Susan, and I think the other issue that comes in is that it's also we've got to take into account the patient. For some patients, it's very hard for them to do daily DOT. It interferes with their life, and I think, again, this is one of those vignettes, I'm going to have to move on for the sake of time, but it's one of those vignettes that really point out that it really is, as Susan said, and John and Pete and Patty, is that you've got to take in all the patient's characteristics, you got to take in the resources, you got to take in your experience. I mean, one of the questions that I keep being asked, what about twice weekly versus 3 times a week? And I think we'd all agree that 3 times a week is preferred, but for some patients, especially programs that have success, 2 weeks may be okay. But again, you got to understand, as John pointed out, which patients may be at risk. We need to move on to vignette number 2, but I want to thank for John, Peter, Patty, and Susan for this one, for everything you shared, and we'll get back to you real soon. We'll have questions later. So if it's okay, let's switch to vignette number 2, and Al, John, and Phil, I think you guys are up. How about that? So let me read this. The guidelines indicate that a 4-month treatment regimen is adequate for the treatment of HIV uninfected patients with paucibacillary TB, meaning smear and culture negative. A foreign-born patient has a PCR that's positive, culture negative TB. In Minnesota, where it's freezing again, so I don't know, but 10 to 18% of the cases are INH resistant, and a very large percentage of those are from Somalia. And the question is, should patients be treated with these 4 drugs for 4 months for culture negative TB, or should they be getting 6 months? And what about the use of daily or intermittent in these cases? And again, I'm sorry, but John, I'm gonna get on you again, because it seems like they like to talk about the cold. So from a cold perspective, what do you think?
Yeah, no, this is a great vignette, and this is a scenario that we struggle with on a regular basis. Here in Minnesota, we're really blessed with a very diverse and ethically enriched state population. And indeed, a very large percentage of our patients with active tuberculosis are Somali and Sudanese background and such. And what we're seeing in communication with our state epidemiologists and reviewing our records is that over the last number of years, 5 years or so, we've had anywhere between 12 and 18% of cases from our Somali population that are INH resistant. It's actually much lower this year. I'm not quite sure why. But it does lend concern when we look at culture-negative tuberculosis and how we basically approach that. And I think, the guidelines are very well written where it's articulated for a 2-month initial program of 4 drugs followed by assessment, clinical and radiologic, and indeed if cultures remain negative and there's clinical or radiologic improvement, then the continuation of therapy with isoniazid and rifampin to complete a total of 4 months indeed may be appropriate, and there's some very nice data that's been published to support that. In some of our ethnic groups, though, where we are seeing higher rates of INH resistance in that capacity with our culture-negative cases, we are concerned about simplifying the number of medications. And so because of the demographics of the patients we have in this part of the country, our own bias is to continue all 4 drugs for the full 4 months if we're not able to confirm the organism in culture with a drug susceptibility profile in that regard. I do want to say, and the guidelines do talk about this, but just to emphasize that the quality of respiratory sample collection is paramount here. I can't say enough how often I come across patients that submit very poor samples of sputum that basically is oral spit. Oftentimes we'll do a gram stain, see many epithelial cells. So we really want to encourage our patients as best they can, motivate them to produce quality samples. And actually it's a coached sample with the hypertonic saline to cough up as best they can. Now, in centers that have bronchoscopy resources that can perform a bronchial lavage, that's terrific, but in many centers that don't have that additional diagnostic capacity, really coaching patients to cough up that quality sample is quite important, because oftentimes what's labeled as culture negative very commonly can be the lack of organism growth in a very poor sample, essentially oral spit in that regard. So what we look at here in our demographics where we're seeing a higher rate of drug resistance in certain ethnic groups is we'll continue 4 drugs for the full 4 months. And also we'll look at extending out to 6 months if we are concerned about poor sputum samples that were submitted, or essentially a fairly slow clinical or radiologic response on therapy, or if we're dealing with more concerns about drug resistance, we'll extend out to 6 months as well. I should also mention that oftentimes what we think is tuberculosis, and patient risk factors for TB, ethnic background, context of active cases and whatnot, indeed, there's lots of credence for looking at these patients and saying, I think this is active tuberculosis warranting therapy despite the absence of cultures. But we also need to keep a bit of an open mind of other things that can be present as well, too. So, for example, I've had a few cases of individuals from Eastern Africa coming to the U.S., living here a few years with upper lobe infiltrates that turned out to be an endemic mycosis, blastomycosis, for example, a case of histoplasma. We also see, for example, non-TB mycobacteria, sometimes looking clinically and radiologically like TB, that certainly can be AFB stain positive or smear positive in that regard, but PCR negative. Keeping in mind, too, that other bacterial pathogens, Rhodococcus and Nocardia, can have a modified acid-fast stain, look oftentimes radiologically and clinically like TB, but of course be something different. Lung malignancies as well, sarcoidosis from an aseptic standpoint. So just kind of keeping that broad and differential that tuberculosis certainly has to be foremost on our mind, and this conference is about tuberculosis today. But just putting my infectious diseases hat, we just also have to keep that open-mindedness of other possibilities aside from tuberculosis that may be present, especially in the setting where our stains, PCR, and cultures may be negative in that regard.
And John, remember, we talked about that you were going to leave your infectious disease hat at the door, and you obviously didn't. I thought we weren't going to talk about those other things, right? We're going to stick it to pulmonary only. Hey, Phil, what about intermittent therapy in these? I mean, especially in somebody who's like smear negative, paucibacillary, do you still think it's okay to treat, let's say, 3 times a week or intermittently in these cases?
I don't think the guidelines clearly address that. So this is one of the things where, that I think it's going to be kind of like we talked about with the other situations where people are going to have to decide on a case-by-case basis. But in general, you would be less concerned about giving intermittent therapy in patients with paucibacillary disease. The biggest risks with intermittent therapy occur when there are lots of organisms.
I totally agree with you.
So this situation
Al,
would be...
I'm going to get back to you on 4. I promise you, you're going to start off. So let's go to vignette number 3. And first of all, again, John, Phil, and Alfred, but less John because of that ID stuff. I want to thank you for that. So let's go to vignette number 3. So vignette number 3 is going to be Barbara and Patty and Lisa Armitage. And I want to thank you for joining us today and to address this. So We have as an approach to avoiding ethambutol ocular toxicity, some clinicians use a 3-drug regimen in the initial 2 months when treating children. However, because of the prevalence of and risk of drug resistance, this can be can be difficult to ascertain. The American Academy of Pediatrics and most experts include ethambutol as part of the intensive phase regimen for treatment with TB. So would you use ethambutol when treating a young child with TB? And we get this asked quite a bit, and this one I think we're going to go right to the point. So, Barbara, I understand that you got a guest. You asked Lisa to do this. I want to know how you did that.
All right, Dave, can you hear me?
We can.
This is Lisa Armitage. Yeah, the guidance actually did. The American Academy of Pediatrics originally recommended that you use a 3-drug regimen and only add ethambutol if there was risk of resistance. And so that had just kind of been ingrained for years, because if you had the guidance was such that if you had a child under 11 who you could not reliably test for toxicity and do an Ishihara, I suppose, or a Snellen reliably, then they're saying that you should not use it. So that had kind of been ingrained for years, but really, the difficulty with pegging whether or not there is resistance or not kind of brought the question back. So, what brought, I thought, around the changes, the guidance that came out of the World Health Organization, where they actually looked at all the data that was available. And one of the, I guess, most important facts that you look at the serum peak levels in adults to show their text in there, where they actually look at
Lisa, I think we may be having a little problems. Are you on your cell phone, or can you pick up? I'm sorry about that. You're cutting in and out a little. I'm sorry.
I'm on. Can you hear me?
Much better. Sorry about that.
Now, okay. Okay. So the what was found was in adults, the serum peak levels of ethambutol on standard treatment are closer to 3 to 5 micrograms per ml. But when you gave that same range of treatment to children, it went down to about 1 to 3. So you can see toxicity. It was kind of recognized you can see toxicity in adults in the 15 to 20 microgram, or 15 to 20 milligram per kilogram range, but it was rare. And that consistently in children, the levels that you'll achieve, the serum peak levels, are much lower. And so basically, based on that, the World Health Organization, document does suggest that, an average of 20, but basically 15 to 35 milligrams per kilogram per day should be safe in children. And that was a point about which the AAP changed the recommendations at that point. So absolutely, having young, healthy kidneys is a really important thing. Obviously, in children who have renal disease, just like in adults, you would have to be, very careful in how you dose and in monitoring. But in a young, healthy child, absolutely, I would feel perfectly comfortable in giving the drug.
Lisa, thank you for that outstanding review. I really appreciate it. And Barbara, I got to remember how you got out of that. That was pretty good there. So we're not going to let you out for too long. Let's go over to Vignette 4, if that's okay. So on Vignette 4, we have Alfred, Barbara, and John. And Alfred, I promised it was going to be you this time. So the question is, does the use of adjuvant steroids in TB meningitis provide mortality and morbidity benefits? And the question really is centering around a presentation, or at least a scenario, which is a patient was recently diagnosed with TB. At the time of diagnosis, they didn't know what the drug susceptibility was, but they started therapy, and soon after, now the patient starts developing new onset headache and a cranial nerve palsy, and that was at 6 weeks of treatment. He's been adherent to DOT with first-line drugs. They go ahead and they do an LP, and it's a lymphocytic pleocytosis with a significant increase in protein and glucose, meaning that it looks like it would be consistent with a TB meningitis. So, Al, when you're approaching a case like this, what do you think are the important considerations in a case like this, and how would you personally address, how would you approach a case like this?
Well, the one issue with this case, and I was looking at it earlier, was that we still don't know what the drug susceptibility pattern is, and you seem to have a patient that is deteriorating as you're treating. So I would first be concerned about the possibility of drug resistance. However, the other aspect that could be possible in this case could be sort of an unmasking of CNS TB in somebody who's getting better as you treat the disease. I would worry about CNS involvement if the patient has some other signs of perhaps disseminated disease, a miliary pattern on chest X-ray maybe, and work from that point on. With regards to TB meningitis and tuberculosis, there really are no good randomized controlled trials. But the one challenge in managing these patients is that you have to bear in mind that the blood-brain barrier is a barrier that the drugs have to get through, and seem to get more difficult to penetrate once the inflammation is gone. The standard 4 drugs, INH, rifampin, PZN, and ethambutol, seem to work for most patients. And there's increasing evidence that maybe rifampin should be dosed at a higher level than a higher dose than 10 milligrams per kilogram, perhaps 20 to 30 even, because it's protein bound, and as inflammation is decreased, penetration into the CSF is much more difficult. If I was concerned with drug resistance, I would look to perhaps a fluoroquinolone and linezolid, as well as an aminoglycoside to add to the regimen.
And again, the reason for doing that, if I'm correct, Al, is really to get drugs that have better penetration into the CNS, specifically into the CSF, if I'm correct, right?
Yeah, INH, PZA, perhaps a higher dose rifampin, fluoroquinolone, aminoglycosides, and maybe linezolid would be probably my first go-to drugs.
And sounds great. And Barbara, I mean, since now I'm going to get on your case, since you ditched this to Lisa before. So my question, I guess, to you is, what about steroids? I mean, do you use steroids in these kind of cases, Barbara?
So the treatment guidelines actually recommend steroids in all cases because of the mortality benefit when steroids are added. They recommend high-dose steroids and a taper over, I believe it was 6 to 8 weeks. I actually got this call on Christmas Eve about 7 p.m. And I think Al nicely went through the things you have to think about. Number one, is the patient adherent to therapy? Number two, are they adherent not only to their TB meds but to the prednisone? And we know oftentimes people maybe continue their TB meds but not the steroids after they're discharged home. So that's a really important consideration because I would say about 80% of the time, maybe 90%, when I get this call, what's really wrong is steroids have been tapered too quickly or the patient has not been taking their steroids once discharged from the hospital. And that can really lead to pretty disastrous consequences. And in fact,
Barbara, I mean, you know,
yeah,
I don't
and in fact, the thing that needs, yeah.
Go ahead, I'm sorry.
In fact, the thing that helped this patient and helped him really quickly was a bump in the steroid dose. It was later found the patient was drug susceptible, but the question of whether you need to augment therapy is certainly an important one. You can't be wrong. It's better to augment therapy and back off, you know, in a couple days when you know what's going on. And so I agree with Al, you know, add a fluoroquinolone, maybe increase the dose of rifampin. I actually added linezolid and ethionamide to this guy's regimen.
Like all good drugs to penetrate. I mean, and I'm obviously going to add cycloserine to that, but I know I'm in the lone group there. But I just want to say real quickly, Barbara, that
but you're not going to get it. You're not going to get it quickly in a private hospital. It's really difficult. I just tried the other day. But yeah, cycloserine's a great drug.
Right, no, I agree. And, well, not a great drug, but it's one of the drugs. I agree. You know, I just wanted to say, Barbara, real quick that, you know, I got a consult also on Christmas, but mine was from Santa, and he said I was a bad boy. So it's just a difference in who we're getting our consults from. But let me ask you a question, Barbara, or actually let me ask this to John. So, John, you know, the issue comes down to, we always talk about, if we look at a lot of the studies, they always talk about CNS disease, and they equate that with meningitis. But, John, a lot of the cases we see are tuberculosis, literally lesions in the brain, and when you do an LP, there's no inflammation meaning there's no increase in white cells, the meninges are not inflamed. How do you address that differently, or do you address it differently in any way, John?
Yeah, those can be challenging. Indeed, what may start as a cold tuberculoma may actually turn out to be a more inflammatory-driven focus of TB infection in that regard. And there are also, I've had cases of spinal tuberculosis down the cord itself with reactivary disease tuberculomas that also lend itself into a meningitis as well, too. I mean, indeed, there can be calcified lesions that do remain fairly dormant and inactive in that regard. And many of these cases may not really be picked up because patients are asymptomatic. But in a case like this, certainly with a person who's on combination anti-tuberculosis therapy, 6 weeks into therapy, 3 to 6 weeks into therapy may have more of a dramatic clinical inflammatory response demonstrating that this could be a degree of iris even in an HIV-negative host. Tuberculosis is an immunomodulatory infection. That these tuberculomas actually can swell, can change, and actually cause neurologic sequelae with that, where the steroids in that capacity can also have a beneficial role, certainly before there's more substantial neurologic impairment.
Yeah, I agree, John, and I want to emphasize what you said about it growing, and I want to get back to Barbara's point because I don't think I gave her enough time on that, is that steroids in those kind of situations, because it really play an amazing role, because the real problem is not the organism itself a lot of times, but the body's immune response that's causing the swelling that actually can cause increased pressures, and, you can see herniation. Barbara, again, I want to go back to what you said about steroids and stopping them. I think one of the things that has to be emphasized over and over again, I think you'd agree, that tapering steroids is an art, the same way with immune reconstitution. It's very, very important that you watch the patient closely. And like you were saying, and I want to hear more comment from you, but as, if the patient starts doing poorly and there's no other reason, maybe increase the steroids and not have to go by rote, 6 weeks, but play it by ear. Do you agree with that?
Yeah, David, you're exactly correct. Those of us who encountered this relatively frequently and have been doing it for a long time know that there are a large number of patients in whom you cannot taper the steroids within 6 to 8 weeks, and that the taper must be slow. Anytime you have a neurological symptom, you bump the steroid dose and then you start again, and taper more slowly. And speaking, we've talked about this oftentimes, and some of us have had patients that can't be tapered in less than 3 months, or some 6 months, or some 9 months. And Jeff Stark famously recalls a case that it took him about 12 months to taper a kid.
Thank you very, very much, Barbara. Well, go ahead, please.
Hi. Quickly, Dave, this is Al. I think that there's a lot of ongoing large-scale studies, randomized trials going on right now, and probably as we move forward, genotypes can be defined, and perhaps we could tailor our anti-inflammation management more precisely as we identify specific genotypes for people who hyperreact.
Al, thank you very much. Great point. I want to, again, emphasize, and I hope you guys are getting the feeling about this, that these are really individualized. And as much as guidelines are there to guide, ultimately it always comes down to the individual particular patient and the characteristics, the specifics of the patient, as well as other issues that you're hearing. And I think, again, these discussions really point out what kind of things that we think about that play a role in our decision making. So I really want to thank Al, Barbara, and John very, very much for that. And Barbara, I hate to say this, but don't go too far away, because I want you to start off, if it's okay, with vignette number 5. So this is a newly diagnosed HIV-positive patient with pulmonary TB. He has a CD4 count of 44. And so what are you thinking about, Barbara, when you face a patient like this? What are the things you're thinking about as far as the treatment of the TB, the treatment of the HIV, and how do you address this situation?
Okay, you realize this wasn't my question. It's for John and Phil.
All right, Barbara, I don't want to say here. I just think, I have here, let's do John and Phil, if that's who it is. I appreciate it very, very much.
Comment, but let's give them a chance first.
All right, so you know what? You'll do anything to get out of this.
I will.
Phil, I want to hear from you. Do you want to discuss this? You want to have John do it? But
Well, I'll start. This is Bill. I'll start. So, actually, one of the first things that I think about is being a pulmonologist is that you really want to either have this patient manage or co-manage with someone who's an expert in the area of HIV. So I would probably refer them to someone like John. But just to go through things I would think about, to begin with, you're managing two infections now, right? So there's the TB and the HIV, and they both have to be managed. So antiretroviral therapy is important, and starting it fairly soon, especially in someone with a low CD4 count, would be, I think, within 2 weeks. Then with the TB drugs and the HIV drugs, you're going to have drug-drug interactions that have to be managed, which is, again, gets back to why you really need someone who's experienced in doing this. The next thing is that HIV patients, especially those with low CD4 counts, are more likely to have extrapulmonary manifestations. So some of the things that we talked about earlier, like meningitis and disseminated TB, would be of concern, so we have to keep an eye out for that. These are the types of patients who you would want to avoid intermittent therapy in, because the studies have shown that you tend to get bad outcomes, including failures in acquired drug resistance. And then there's the iris, or the reconstitution. As the immune system is reconstituted, these patients can actually become more symptomatic as you're treating their HIV and their TB. Their immune systems start to get back in functioning well, and you get this inflammatory response, which leads to can lead to worsening of symptoms that may have to be dealt with. And then finally, one of the things that John mentioned in that culture negative case, which is thinking about things other than TB, usually we want to think about the simplest explanation, that the patient's disease is only due to one thing, like TB, but these are the types of patients where you may actually see multiple infections. I've seen patients with TB and cocci, TB and histoplasmosis at the same time, so you have to be aware of those types of things.
I totally agree. I mean, and I think one of the biggest problems you start getting into is, the timing, of the meds, like you said, and as well as the interactions. John, I think I'm going to get this straight this time. John, how do you deal with the interactions between the HIV and TB meds? It's getting harder and harder. I mean, every day there's new drugs, which is fantastic, but while these drugs are coming out for the treatment of HIV, there's not as much known about the interactions between these drugs and the rifamycin, especially in patients who are HIV positive, because a lot of the initial studies are done in quote-unquote healthy volunteers, which we tend not to treat healthy volunteers. But John, maybe you do up there.
Everybody's healthy here in Minnesota. No, absolutely. That's a key issue, and an issue historically in many parts of the world where ART was delayed until after the completion of TB therapy, and it's been shown, I think, quite clearly in a number of trials and nicely articulated in the paper, where HIV co-infected patients actually do much, much better with ART started during their tuberculosis therapy, and outcomes, of course, are even better when the immunologically advanced HIV co-infected patient is started on combination ART within the first few weeks, as Phil nicely outlined. And I will say, I think this is a wonderful example of the vital role of multidisciplinary case management that public health, TB, and county health providers do, public health, in that really having a combination team effort where case managers, TB controllers have an ongoing dialogue not only with TB providers but with HIV providers as well too, so that there's clear discussion and articulation what the HIV program can be oftentimes predicated on what the combination tuberculosis program is going to be. So given that, over the last 15 years, there's been a number of new antiretroviral agents that have been introduced that actually do not have the profound drug interactions that, for example, the protease inhibitors have historically encountered. So, for example, of the non-nucleoside reverse transcriptase inhibitor, efavirenz is commonly utilized, and this is a drug that it's co-formulated as a triplet and can be given with either rifampin or rifabutin. The integrase strand inhibitors, raltegravir and dolutegravir, with some dosing adjustments, also can be given with the rifamycins. And so these are considerations that the HIV provider will think about when they know that their patient is being treated for tuberculosis, is to look at an antiretroviral program that not only is effective for that person's HIV strain, but also has minimal drug interactions with the combination tuberculosis program. I will say that certainly protease inhibitors continue to be commonly used. They're a good drug as part of a combination regimen in that regard. This class of antiviral agents does have a profound interaction with the rifamycins, both with rifampin and rifabutin. Rifabutin can be used with the protease inhibitors at a dose-reduced fashion. I would say that in situations where a protease inhibitor-based ART program is utilized in TB combination therapy with rifabutin, my own personal recommendation on this is that the HIV therapy is given DOT with the TB therapy. And the reason for that is that if an HIV-infected patient's not taking their ART well, that's protease inhibitor-based, the rifabutin that's given 150 milligrams daily, the dose is dependent on the patient taking their protease inhibitor. And if they're not taking their protease inhibitors by not being on a DOT program, then you're significantly compromising the rifabutin activity by being underdosed in that regard. It's also, in addition, as you kind of were alluding to, David, that many of these immunologically advanced HIV patients can have enteric malabsorption from the AIDS, HIV infection itself. There can be other opportunistic infectious processes going on that Phil was alluding to that also can compromise malabsorption. So these patients do need to be monitored very, very closely. There can be a role for therapeutic drug monitoring in patients that may have malabsorptive symptoms, ongoing profuse diarrhea, or may not be responding robustly to their tuberculosis program as what was being hoped for. And as Phil mentioned, I think these are some of the issues where having that multidisciplinary engagement with the HIV provider, the TB provider, with public health case management really being the central coordinating quarterback through all this, really having those open lines of communication.
You're totally right. As long as the HIV doc is not an infectious disease doc, everything is fine. Hey, Pete, you know, I know from a programmatic standpoint, immune reconstitution can really be an issue. You know, I know you guys face some issues with it. What would you like? You know, I know you have some comments. Go ahead, please.
Well, I just wanted to kind of broaden the discussion a little bit. I mean, we've heard of IRIS in the last two vignettes, number 4 and number 5, and so I just sort of wanted to ask John and Phil, and obviously Dave, you and Barbara, anybody else, just in general, you know, how concerned should TB programs be about, you know, seeing immune reconstitution syndrome in their TB patients, and are there scenarios in which it's more likely to see IRIS, and then what are some signs or indicators that a TB nurse or case manager should look for, either that a patient is at risk for IRIS, or maybe that they're sort of at the beginning of manifesting it?
Phil or John, you want to handle that?
Sure. A couple of points. A key feature when we talk about the early onset of ART, there is an exception to this that's articulated in the guidelines, and that's with tuberculosis meningitis. And that's a scenario where the early initiation of ART actually can be problematic because of meningeal iris, CNS iris, that can be devastating in that capacity. So in that particular setting, actually holding off on ART for about 8 to 10 weeks can actually be advantageous to help minimize that onset of iris, or minimize or potentially defer iris in that capacity for a co-infected tuberculosis patient. And otherwise, I mean, the more immunologically advanced an individual is, there's a greater chance of iris. Certainly this can happen in any stage of HIV infection, and we've actually seen it in HIV non-infected individuals as well too. It presents in all sorts of various forms. Perhaps one of the easier, more recognizable forms of iris is an extrapulmonary TB form with lymphatic tuberculosis, where the lymph nodes will swell up after a few weeks of combination ART. And again, not limited to HIV-infected patients. This can happen very nicely in HIV-uninfected patients in that regard as well. Iris is a diagnosis of exclusion, so it may look and smell like iris, but especially in an immunologically advanced HIV-infected individual, you want to rule out other potential opportunistic infectious processes, endemic mycoses, cryptococcus, sorry David, other types of things that may be mimicking this, or even malignancies in that regard. Could this be a primary lymphoma that's masking as an enlarged lymph node in that regard? The patients that I've had with iris, now this isn't everyone, but most of the patients that I've had actually started to feel a little better on therapy when they were developing iris-like symptoms of adenopathy or things of that nature. Now, with meningeal TB, they don't feel better. They can actually be quite sick very rapidly. Fever can be a manifestation as well. These may be culture negative in that capacity as a microbiologic clue that you're moving in the right direction. But point being, it's a diagnosis of exclusion, that you're not missing some other infectious process malignancy to zero in and say this could be iris, and thus look at an appropriate immunomodulatory program, whether it's nonsteroidals for the more mild cases, or even looking at a short course of prednisone steroids to help suppress that robust immunologic response to get the patient through those symptoms.
Bill, that was fantastic. And as you know, just to point out what you said, when we did our original series on, immune reconstitution, when we named it the paradoxical response, because exactly clinically, as Pete was saying, what's very interesting about these cases, though it's not a gold standard, you still have to rule out others, is that the patient actually is clinically doing better, meaning they're eating, they're gaining weight, but they're having fevers to 103 and their neck is swelling. But you're exactly right. That is one of the unique features where the numbers look worse, the x-ray looks worse, but they actually look better. But Phil, thank you for that excellent review. Let's go to vignette number 6. Number 6 is that we have a patient who has intermittent treatment of transplant. He's a transplant patient, I'm sorry. And going over, what is the significance of treating patients who are recipients of transplant on their immunosuppressive drugs who have TB, to go over, the significant drug-drug interactions and to avoid rifamycin. So for this, I think we have Barbara, Pete, and Susan. And Barbara, I think what's your approach in these transplant cases? I think you'd agree we're seeing more and more of these.
Thanks, David. Yeah, it seems like we are seeing more TB in transplants, but they seems like they come in clusters like every other good TB thing. I think it's important to not identify all transplants as exactly the same. If you have somebody with a kidney transplant, if worse comes to worse, they can lose that kidney to save their life. If you have somebody with a heart transplant or a liver transplant, you have to fight a lot harder to save that organ at the same time as trying to fight to cure the TB. And they're not, if the patient can actually either die of organ rejection in those cases or TB or both. And unfortunately, I've kind of been aware of all of those things happening. So obviously, just like with HIV, you try very hard to be able to have a rifamycin in the treatment regimen for TB. You recognize that causes significant interactions with the drugs that are being used to control rejection. I use rifabutin rather than rifampin, and I don't think I've used rifampin in a transplant patient, but I have used rifabutin fairly frequently. It's really important to identify somebody on the transplant team, usually that's the transplant and maybe the ID doc, but really working with the transplant surgeon themselves, because they're the ones that are willing to be aggressive and to treat, and if you need to really carefully monitor the immune suppression that these individuals have. They can do serum therapeutic drug level monitoring for their various immunosuppressant drugs, and many of the transplant programs have other ways to manage how well their patient, or evaluate how well their patients are being immunosuppressed. So from the different drugs, but I usually use rifampin. Rifabutin. I would not use intermittent rifabutin. If I'm going to stimulate the cytochrome P450 enzyme system with a rifamycin, once that patient's been on a rifamycin for a couple weeks, it's really not going to vary day to day much versus 3 times a week versus 5 times a week. This is probably the most high priority patient, even more so than an HIV-infected individual on antiretroviral therapy, that you want to give priority for daily DOT and for DOT. This would, as a physician, I would refuse to order intermittent therapy or be responsible for the patient if the patient was given self-administered therapy. In the worst case scenario, you do what you have to do, but this patient needs daily therapy.
much. Hey, one of the things I think, Susan, you would agree with, is like, is the communication between the TB team and the transplant team, because there's so much going on. And do you want to comment on, your experience or what recommendations you might have as far as, how important it is to communicate what's going on between, the TB program as well as the transplant team?
Yeah, David, that's really important, and Barbara mentioned that as well. And identifying someone on the transplant team to be in really, really close and real-time communication with the TB team is absolutely critical. And as Barbara mentioned, the transplant folks will want to monitor very closely the blood levels of the immunosuppressants that they're using to maintain the organ and prevent rejection. So, and I think it's a good principle for all immunosuppressed patients, whether it's transplants or people on TNF-alpha inhibitors or HIV patients. It really, really requires a good relationship and very close communication with the other team.
I totally agree. And like Barbara said, while you can lose the organ, I think when you're discussing these kind of issues with the transplant team, they really like to hear that you are looking, out for the organ and making sure that we are protecting and encouraging the correct immunosuppressive levels, especially, at least in my experience, when we explain that we can actually look at drug levels not only for the immunosuppressants but for the TB meds. I think it gives that level of confidence, which I think is important. Well,
and they'll usually have, Susan here for a sec, they'll usually have their own case managers who are also closely looking after these patients, and so that facilitates, good close interaction.
Exactly, and also more resources we can lean on. I totally agree. Well, let's, if it's okay for the sake of time, we're going to move over to vignette number 8. So we're going to go to Patty and Susan, and it says, I think one of the things that I think probably, if there's one recommendation that probably has more TB controllers and clinicians scratching their head, is this: why is case management DOT a conditional requirement rather than a strong recommendation? I think for any of us who have ever done TB, the question is what? So Patty, you want to comment on that?
Yeah, and so when I saw that recommendation, I was a little taken aback because with the case management, but I do understand it because there's really no way probably to quantify case management and how that works. But one thing that I think that's important is when I know there's a lot of points in the guidelines of what case management is, but I think sometimes a lot of times it goes back to DOT, and case management is so much more than just watching people take meds. With the DOT, we have patients with so many social issues. We go into a home, and besides just watching their meds, you find out there's kids in the home. This just happened. There's kids in the home. There's no food in the home. They're getting kicked out. So that can take just, hours of your time just trying to navigate that patient to get to the point where, they can think about their disease besides, their basic elements of food and shelter. But I think case management, a lot of our patients would not succeed if they didn't have the support of the nurses. And I've talked to nurses around the entire country, and they're all under that same pressure of having to do case management and social work, and they all do really, really fantastic jobs getting the patients to the end point of treatment.
And Patty, I agree, and I think part of this question, I got to be honest with you, is a little tongue-in-cheek, because I think it really goes back to the grade system and really understanding what the grade system is, which is, I think sometimes we kind of mix up the grade, system language versus our everyday clinical practice language. And Susie, would you like to talk about what went into and some of these suggestions, and what were the limitations and constrictions you had on you when you were putting these recommendations together?
Yeah, thanks, David. And Patty, I was listening to what you said and agree wholeheartedly, and I know that the committee did as well, agree with the importance of DOT and the importance of case management. Just stepping back, though, this grade approach, which is what's required now for writing these guidelines, the grade approach uses a certain strict approach where the committee has to look at the evidence from published studies in a formal way and then apply certain criteria to look at how certain one can be based on the evidence. And really simply put, the data for DOT or the data in the published literature for case management there's not a whole lot of data, and it's not of really high quality, at least when one applies these grade criteria. And so this lack of high quality evidence is really what drove the conditional recommendation. And in the grade approach, it's either conditional recommendation or strong recommendation. And so it's more sort of a technical issue that drove this conditional recommendation. I would submit that all of the committee members feel quite strongly about the importance of DOT and case management. But again, in the grade approach, our beliefs don't really matter as much.
And Susan, let's be honest, it's really hard to define directly observed therapy and case management. It's not a very it's very gray, I think you'd agree.
That's a great point, David, and I think that that's one of the reasons why there's not a lot of published literature on these things, is that both DOT and case management are multifaceted things, and they don't really lend themselves very well to the type of studies that get published and in the literature. So I think that's and I think when we look collectively at our program experience, probably case management is responsible for the success of U.S. TB, broadly speaking. But those types of things don't appear in the literature. So one thing that we can do is share in the literature our own programmatic successes that will bolster the literature. And then really as a final comment, I would mention that, I think we all realize that not all things in life and not all things in medicine require randomized clinical trials for us to know that they are good. I don't think we'll ever see a randomized controlled trial of whether having a parachute saves lives for people jumping out of airplanes.
I agree 100%, and thank you very, very much. For the sake of time, because we really want to give an opportunity to answer some of the questions that have been coming in, I think what we're going to do is, Pete, you brought up a very, very good question about, the whole idea of missing, dosing. Like, one of the things I thought was very ironic, to be honest with you, was that one of the reasons or rationales for not recommending twice-weekly therapy was that if you miss one therapy and twice weekly, it's the same as giving weekly therapy. And we know that weekly therapy doesn't work. But, I mean, my only problem, and again, this just may be me, but my only problem is that kind of rationale is if you miss all of your appointments, even if you're on daily, if you miss all the meds, then it's not going to be effective either. Is that a rationale not to recommend daily? But maybe that's me. But, Pete, I know there's questions, so how do you deal when you have somebody on intermittent therapy? One of the advantages of daily is if you miss one, you have the others. With intermittent, it's not so easy. I think there's some confusion among the programs, or at least some questions about the programs, about how do you handle intermittent therapy. Is that correct?
Well, I think yeah, David, you've really hit it on the head. I mean, I think as long as as long as we've been using DOT in the U.S., that's been a question. And I think with Susan, I think you did a really good job, articulating the kind of the nuances of the grading language and how that creates sort of the appearance of a much more strict kind of approach in the way that these new guidelines are written. But the question that I wanted to raise, and I wanted to put it in here in the context of sort of case management and the relevance of case management and DOT, is it's a scenario question that was actually presented to from one of our TB controllers, and so they're saying you have a patient who's on 3 times a week DOT, and due to scheduling issues, if you're normally doing it on Monday, Wednesday, Friday, if the patient ends up, say, missing a Friday dose in one particular week, what is the recommendation there? Should you skip that dose and just pick up the next Monday? Should you attempt to, if you know in advance, should you try and reschedule and maybe do the DOT on Thursday? And then if you miss doses, would you recommend those missed doses to the end of treatment, so essentially you extend treatment maybe by a week or two, or do you try and squeeze them in somehow? So I just, that wasn't really articulated in any of the scenarios, but I just wondered if other panelists would care to comment on that.
Yeah, Barbara, Al, Phil, John, I always ask John last. Patty, any comments, or how are you guys handling that?
Well, when we have some intermittent therapy, we count the doses. So if they miss a dose, it is going to extend their therapy, which we also use to encourage them not to miss a dose because you're just going to be on the medication longer. But we also look at the compliance every month, and if their compliance is dropping like below 80%, they might be taken off of intermittent because, they're missing too much. So we have to try to go out and find them more often, and they might have to go back to daily dosing.
Yeah, but with regards to the scenario that Peter had mentioned, Monday, Wednesday, Friday, you miss Friday, perhaps your only choice is to wait till Monday, and that week would have received 2 doses, right? I don't know how Barbara or the others would approach that scenario. Although, the more doses, the better.
Yeah, this is in Minnesota the same. We look at counting doses, and we use that to incentivize the patient that if there are missed doses, that will, as Patty mentioned, that's going to extend the duration of therapy. And we also look at what are the issues that are posing as barriers to missing that dose. Is it arrangement of not going to work for DOT? Is it a home issue? Is it an embarrassment issue of the patient for where the healthcare worker is prescribing the DOT? So we really try our best to look at creating a scenario where the person, A, is going to be there, B, is comfortable receiving the medications, and then C, incentivize them by understanding that the more they're compliant with the program, the shorter their overall duration will be.
This is Barbara, and in Texas and generally in many of the states that I consult with, they do the same thing. They count, if it's intermittent therapy, you count the number of doses. Actually, for daily therapy, you're supposed to count the number of doses too, and we typically add them to the end of treatment. But I agree that if you miss a Friday dose, that means you go from from Wednesday to the next Monday, and that can probably happen once or twice, but you cannot have that kind of situation happening early in therapy with a high bacterial burden and expect to have a good outcome. So, and that's one of the things, even though I kind of repeatedly remind the nurses in the clinic and the outreach workers that I need to know and know quickly if my patient is missing doses, because if you come to me 2 months later and tell me, oh, the patient's only had 70% of the doses for the last 2 months, it's really hard to correct that. But if you hear about it quickly, you can respond to it. And at least if the patient is on daily meds and they miss, a couple doses, it tends to not fall between 80% quite as rapidly as it does with intermittent.
So, Dave, this is Phil. I just want to. I think this kind of question underscores the difficulty of writing guidelines to cover every possible scenario and why you do have to apply them and think about individual patients, because some of the points that Barbara and others have made, there are other factors here. It's not just that dose. So is this the only time it happened, or is this a repeated problem? When does it happen in therapy? It's more of a problem if it happens earlier in therapy. I mean, if this is the last week of therapy, how much of influence does that really have on the patient's outcome? So how sick is what burden of disease did the patient have at the start? So I think that's why you have to look at a lot of factors when you look at these decisions.
Without a doubt, Phil. I think it's such a great point. Again, over and over saying, look, that's why this conference is all about what clinical factors you have to take into account when making decisions. And again, the guidelines just try to give a framework, and so is these discussions to how to approach. And I think everything you guys have brought up is just so important. Hey, we're now, what we're going to do at this, we've been watching all your questions and answers, and we're going to try to put them into a kind of a format, putting some questions together and ask the panelists to see if we can get the answers. Again, we really like to hear from you. So if you guys don't mind, if you would put your questions in the Q&A, and I have Karen sitting next to me, and she's watching them all, and we'll try to ask them to panelists. So on this whole intermittent therapy, does anybody want to talk quickly about, biweekly therapy? I mean, we're getting a question, can you still use biweekly? And then we got an interesting question I think really is, one of the, at least for HIV positives, it seemed to speculate that one of the problems with biweekly therapy was that, when we gave INH and rifabutin, the INH has such a short half-life and the rifabutin has such a long half-life that we were leaving rifabutin alone. But a lot of new work is being done on high-dose rifampin, and I know it's too early to talk about that. We're still waiting. It is interesting that it was alluded to that high dose may solve some of these issues. John, Barbara, or anybody, Al, you guys want to comment quickly on first intermittent, biweekly versus 3 times a week, which we kept, is there still a role for twice weekly? And what do you think about the potential possibly of high-dose rifampin?
I think, this is Barbara, I think high-dose rifampin is definitely going to be coming at us, and it's going to be helpful and effective. I think twice-weekly therapy has very little role. You have to have a very well patient with very little amount of disease before I would consider twice-weekly therapy.
This is Al. I agree with Barbara. I mean, I learned from Ray McDonald, and really his principle was in treating TB, you really have to give as much doses as possible, if possible, to achieve success, and we try to do it as much as we can here, including weekend dosing. And as Barbara said, twice-weekly dosing now is the simplest form, perhaps, of non-HIV, not severe pulmonary TB.
Actually, I'm going to play a little bit of devil's advocate, if it's okay, just for the biweekly. So it's kind of interesting. A lot of programs for the longest period of time have been using daily for 2 weeks, and then they go to a biweekly program, a biweekly regimen, including a lot of patients in Florida. And it all comes down to that the relapse rate to using that in the majority of patients is relatively low. And that's the question, relatively low, meaning, running less than 5%. And I guess as kind of a devil's advocate, just to stir a little conversation, is I guess how much failure are we going to allow versus if we don't have the resources, now we have to start putting people on a self-administered. And I guess that's the question, because I think the issue is not like if you use biweekly, everybody's going to fail. I think everybody on this program who's done TB knows that most patients will get cured with that. It's just that is it the most effective way? And I think that may be an issue, but I'm just playing devil's advocate. I'm just interested in what you guys have to say.
Yeah, this is John. I agree with you, David, that the experience with the BI week treatment's been pretty good. It's just if you're the patient who is part of that 5% with recurrent tuberculosis, then arguably 5% is going to be too high. And when there is published data showing further benefit of more frequently administered therapy, and in the context of the communicability of this particular disease, unlike diabetes, for example, I think we really should make every effort we can to optimize the delivery of therapy with more frequent dosing, especially in those cases, as Phil and Barbara alluded to earlier, with higher disease burdens, immunosuppressed patients, things of that nature, but also in the context of what are the resources of public health. Can they deliver on that? I think there are many areas across the country where twice-weekly therapy still is going to have to be an issue until there are more resources available for more effective DOT, more frequent DOT in that regard. And it's going to come down to selecting the appropriate patient who most likely will still respond quite well to that program.
John, so well said. Thank you very, very much, all of you, on that. That was perfect. I guess one of the things that's so funny, when we started talking about the first one in intermittent therapy, I don't know if you guys at home or at the office, I should say, saw, but that chat lit up about video DOT. I can't tell you how many video DOT questions came up. So I guess I wanted just to comment on video DOT. It sounds like more and more programs are utilizing it and having, I guess, good success. And I guess I want to open it up to maybe Patty or anybody on the call about what's your experience of video DOT and what concerns specifically about security might you have or might not, and what's worked. So let me open that up to the panel. Video DOT, what do you guys getting up in the middle of the night and chatting like other people, or what?
Yes, I have. I've done video DOT. We've used it a lot. We've used it a lot in New Jersey, throughout the state. But it's not really such a new concept. We've used it way back when it was actually machines and there was landlines. And so, you know, you have to write your policies to make sure that you do have it secure. You know, it's a secure line, and you're careful with your confidentiality. But had great success with video DOTs as far as people completing treatment. It worked for people. We've even had people on intermittent therapy doing video DOT that were very compliant. So I think we say here that is not the first choice. You know, that's the choice of when there's no other way that we're going to get this person DOT'd, though.
You know, that's great. Let me ask you something, and it's a great question. You know, some of the most simple questions are the ones that are the best. There's a great question on here that says, please define video DOT. And I think what an amazing question. So I'm going to challenge you guys, define video DOT the way you guys are using it, you guys are seeing it right now, because I think probably while we all have a general concept, we all may be using it in a little different way. So Patty, since you started, you want to just define kind of slightly what you've been doing?
You're right. Well, we really should call it electronic DOT, because video sounds like we're looking at a video. So I've used a lot of different applications, but mostly it is, you know, it's live. It's either, you know, we have one that's encrypted now that we use, but it's a live interaction. But I've had a situation with the patient that sometimes, because of the situation, it couldn't be a live encounter, so they would tape themselves, send me the video, I'd watch it, and then, you know, follow up with a phone call later. So it was kind of a combination of, video and DOT, but I know some places, you know, there's some apps that just have the video, and then you send the video, and, you know, I didn't like that interaction personally, because as a nurse, I'd like to make sure that I'm following up and asking the right questions, but it did work in instances where he could not have a live discussion with me.
Yeah, and you know, I think if you went around, Pete, Sue, Al, Phil, John, Barbara, I mean, are you guys using video DOT? I mean, you know, and if you're using it more and more, working, not working, what are you finding? Anybody?
So this is Barbara, and I think it's awesome. When I consult with groups across our states, they are finding it to be very helpful. We had wonderful success with it at the City of San Antonio, but now that they've decided they need to review the policy, so it's on hold temporarily. But I can tell you there are patients we could not have finished treatment, and I do think it worked and worked very well.
Yeah, that's great.
I think that you know, we have such a great document in front of us with the current evidence, and we have to use as much of that evidence for the benefit of the patients. And I think this is where the hard work begins, is how do we identify best practices. And I think the technology is going to be an important part of how we will continue to deliver quality care. To remember that video or electronic DOT does not replace case management, so we have to be creative in terms of how we use technology. But inevitably, we are going to be increasingly dependent on technology to extend ourselves.
So, Dave, this is Phil. I think there's no formal recommendation about actually the use of video DOT. And I think that unfortunately gets back to the problem of those things are, when you get into guidelines, you require some amount of literature on this peer-reviewed published literature, which there's fairly limited amount right now. And it would be nice, because we know that there are a lot of programs that have had very good experience with this, so it would really be helpful to see as much of that published, which would allow a more formal recommendation to be made. We're actually looking at working with at least one program on trying to do a more formal study. So right now, all we can say is it's a programmatic decision, and programs should use it or not use it, and depending on their experience, ability, and so forth. But I just want to encourage that the more that is is actually reported in the literature, the easier it would be for us to actually make a formal recommendation in favor of it.
Phil, you know what? I got to tell you, that is exactly how I think we're going to need to end this conference, because I think it really is the essence of everything we discussed today. You know, this, as Al said, is an amazing document. I want to give over and over again our appreciation to the people who really got together and put this together. It's one of the most well-referenced, great reading, I think informative. But at the end of the day, it only can do so much, because what limits it and limits its recommendations is the amount of information we have. And that's where, Phil, I don't think you could have said it any better, that all of us have to share our experience and be able to share it among each other, so we all learn and all become a better program, a better TB program, so we all can go towards our goal of one day eliminating tuberculosis. And that's why I think these kind of conferences are fantastic. And I just think I can't thank the panelists enough. I want to thank really Peter, Susan, Al, Phil, Barbara, John, and Patty for making a really, really fantastic conference and making it clinically based. And we can't thank you enough. I also really, on behalf of all the centers, we want to thank you for joining today. And I really don't get an opportunity, and I don't think any of us get enough of an opportunity to say how much and how honored and blessed we are to be able to work with all you out there and be medical consultants. You might think that we're doing it for you, but no, we do it for us. I think all of us would agree. All of us who have the opportunity to interact, all of us who have the ability, to learn from everyone out there. When we're doing a consult, it's not one way. It's always both ways. And we can't thank you enough for that opportunity to serve you. We really want to thank you over and over again. We want to thank you for, joining us today. And lastly, I want to again say that remember these guidelines, a great document, but remember they always have to be individualized and based on the resources and experiences of your program. So lastly, what I'd like to do before I turn it over is I want to thank everybody again. I want to thank you for everything you do for tuberculosis, for protecting, our citizens against this disease and helping our patients get better and regain health. So until we meet again, until we speak soon, thank you very, very much. Have a great, until we speak again, great time. And I'm going to turn it back to, go ahead, please.
Thank you, everyone, for attending today. Just as a reminder, please fill out the evaluation and follow the required steps depending on the type of credit you are seeking. In addition, this webinar was recorded and it will be posted and distributed early next week through each of the RTMCCs. Thank you again for our presenters and thank you for joining us. Bye.